let's go ahead and begin. So this week, or this month, I guess, we're talking about laryngospasms and bronchospasms. These are super common things you're going to see in the PACU setting mainly after a general anesthesia. I'm sure there are ways it can happen with other different forms of other forms of anesthesia, but probably general is all I'm talking about here. So here's kind of the layout of how I'm going to do this. We're going to talk about what these topics are, different risk factors for them, ways to prevent these things from happening, and then what to do if it does happen, how to fix it, how to treat it. So the first thing we're going to go over here is laryngospasm. Laryngospasm is the definition of it is a prolonged exaggeration of the glottic closure reflex. What happens is the superior laryngeal nerve can get stimulated and cause the epiglottis to cover over the vocal cords, or the vocal cords themselves, which have pretty decently strong muscles, can close as well. But it's the reason that's a bad thing, obviously, is because air won't be able to pass through. This could be a pretty dramatic looking problem. You can have lots of, mainly desaturation is the biggest issue, is just oxygenating, but there's some other problems that can happen as well. There's two different types of laryngospasm. Partial, which is the one you actually hear, involves some air movement going through the cords, which produces typically a real high-pitched squeaking noise or something like that. In the form of complete laryngospasm, this is where there's no air movement whatsoever, and it's kind of the silent killer. You may not hear anything until your patient desats. So what are some risk factors for specifically laryngospasm? So the biggest, I think, issue that can happen is in any sort of airway stimulation. I put manipulation on here, but it's really stimulation during any sort of light plane of anesthesia, and we'll go over what that really means, light plane of anesthesia, here in a little bit. Vocal cord irritation, secretions, blood, boogers, anything in the back of the throat that can touch the vocal cords during a specific period of anesthesia, usually emergence, but it can happen on induction in the OR as well, can cause that. Mostly this is a young people problem. I say mostly because it can happen in any age, but it seems like the younger you are, the higher the risk for laryngospasm, especially kids under the age of 3. Why 3? I have no idea. That's just a thing that I've seen and I think is written somewhere, or I might have just made that up. I don't know. No, it's under the age of 3 is the higher risk. As you get older, everything grows and you just develop a lot more of an airway that can have air pass through it. So again, older people, not as much of a concern, even though I'm willing to bet adults probably have laryngospasm and we just don't see it because it's a little more self-limiting. They have bigger oxygen reserves, and they probably do it and then quit doing it. They never desatted and it was never an issue. Anyone with a recent respiratory infection, COVID, etc., anything really that causes that. How long after, I wish I remembered this, how long after some sort of URI especially, whether it's just kind of snotty nose or drainage, etc., how long after that is a safe anesthetic? I don't know. We haven't quite agreed on that as a medical population. I think 2 weeks is reasonable. I think, especially with COVID, somebody mentioned something about like a month or 2. I think that might be a little overkill, but what I'm basically hinting at is that even after you recover from any sort of upper airway infection, you're still very sensitive, and that sensitivity manifests as laryngospasm sometimes. Anyone with smoke exposure, I put exposure instead of smoking because, again, this is a thing that happens in kids a whole lot. If they're around cigarette smoke in the house, that's a risk factor. Of course, the more smoke they're around, the worse this can be. Obstructive sleep apnea, again, that's a stimulation that can happen. If they're having a lot of snoring and things like that, that can cause laryngospasm. And any people with airway anomalies, if you have something back there that could cause an issue, that's also a thing. And then people, and this is, I probably should have listed this a little higher, airway procedures are huge for this because, again, we have stimulated the back of their throat, and that can cause a problem as they're waking up as well. So tonsillectomies and adenoidectomies, this is huge. Anyone that's recovering patients over at Health Center, where we do a lot of those, probably knows that's what can happen over there. ML&B is microlaryngoscopy and bronchoscopy. Anytime we're doing any sort of vocal cord surgery, anything with an open airway, what else? Yeah, kind of all those back of the throat sort of things. That stimulation doesn't just go away, especially if we've been cutting on something. So as they wake up, their body's going to be reacting to that. Hopefully not, but most of the time, yes. There we go. So ways we can prevent this. Delaying elective surgery for patients with current upper respiratory infections, and I should put current or recent URIs. Another thing is suctioning secretions away from the vocal cords. I need to throw in a caveat here. That does not mean that every kid that comes to PACU, we need to just start suctioning to make sure they're dry. If you suction a patient in the wrong phase, we'll get to the next slide and I'll mention suctioning, okay? So anyways, clean up what's back there to prevent things from stimulating vocal cords. And then as an anesthesiologist, I can actually alter some plans. This isn't anything y'all are going to be able to do or anything like that, but just so you know, there are things we can do as anesthesiologists that can reduce that risk, one of which is high-risk patients. It's been proven that if you don't intubate them and put in something like an LMA for a procedure, they have less chance of a laryngospasm. Again, that irritation on the cords, once you extubate, doesn't necessarily go away immediately and can cause something like laryngospasm as they're waking up. So if I can identify someone who's going to be at high risk and I don't necessarily need a physical endotracheal tube for that procedure, I can do this and help reduce some of that risk. So this is my really crude drawing of how people wake up from anesthesia, okay? You often hear about people talking, or especially anesthesiologists talking about phase 2. Everything's about phase 2. So here's kind of how this works. Working from the bottom of that y-axis, I think it's y-axis. I haven't taken any math classes in a while, but the vertical axis, we'll start at the bottom. As you go to sleep, you obviously go from consciousness through phase 1, phase 2, and then phase 3 and 4 are your deepest levels of sleep. Kind of a general anesthetic should stay well into probably phase 4, but 3 and 4 are kind of interchangeable for consciousness purposes, so I kind of drew this like that. So as you wake up and emerge from a general anesthetic, you go through it kind of from left to right on here. So I'll say this was like a gas-based general anesthetic. So as you breathe this gas off, you're going to move, not real fast, but as you breathe the gas off, you're going to move from a really deep plane of anesthesia to awake. Phase 2, let me get a little laser pointer. Is that a thing I can do? Oh, there we go. Okay, so phase 2 is what I'm really talking about right here. So you're going to linger in this plane for a little bit before you continue on to other levels of like consciousness recovery. And during that phase 2, where the heart rate's increased and your breathing can be variable, all those things, that is the biggest point in time that someone can have a lot of anesthesia complications, mainly breathing problems, and mainly laryngospasm is the thing we worry about in phase 2. This can be a stimulation from moving them around in bed, to starting an IV, to suctioning. All of these things can actually, it doesn't have to be just an airway manipulation. You can actually cause people to laryngospasm from different types of stimulation. I once myself had an attending, Dr. Heron, and he used to freak out every time that there was a lot of noise when patients were waking up, because he swore up and down patients would laryngospasm from a lot of audio stimulation. I believe that's actually true. He was pretty protective on it, but I think that can actually happen. So this is what I was trying to say in the last slide. If you are get a patient come in, the first thing you should do is not just go suction their airway, because you can actually take a very normal well situation and cause a laryngospasm. So if there's nothing wrong with it, don't do anything. If they start to laryngospasm, go for it, because they're already kind of doing it. But that's my point on this whole thing. Okay, so did I explain that decently? I guess? Okay. So the biggest part of that is phase 2. So here's a couple of different things that I wanted to point out. There is the image that I'm going to be talking about right here on the left side is going to be what's called Larson's maneuver. This is also referred to as the laryngospasm notch, hence the website right here from Up to Date. But it's just underneath the ear, right behind here. Here's the angle of the jaw. It's going to be right about here. And if you dig your fingers in right there, there are, I believe, ganglia there. Anyways, if you do it to yourself and press, it's kind of stimulating. It doesn't feel good. And so what this will do is move you, if you're in phase 2 and you're having a laryngospasm, it will move you to a lighter plane of anesthesia. That's the whole point of doing that, is to kind of wake you up, if you will, and help you recover some of that function to normally open up your vocal cords when you're taking a big deep breath, and that will help break the laryngospasm. This person's also getting suppositive pressure through a mask, which I'll talk about here in just a little bit. But a lot of this has to do with just moving out of that phase 2 level of anesthesia. On the next slide, we'll get into treatment, but let me talk about this other thing real quick. So that's the laryngospasm notch. Steve Lamb's really good at hitting that thing. So this right here is the other piece of this puzzle over on this right-sided image. This thing is a flow inflating bag for resuscitation. You see this a lot with like neonates and things like that, and kids. I try to bring kids that are high risk for laryngospasm to PACU with one of these things. I wish I had an oxygen hookup down here because I could show you, but what I think I'm going to do is make a separate video, just a real quick thing that I can post online as well, so to demonstrate how to use one of these. But basically, here's what happens, and I'll go back to the PowerPoint and show you here. So you've got oxygen coming into this whole circuit right here, okay? There is a valve right here, demonstrated at this institution at least, is right here, this little green thing. There's a little, there's a red indicator inside that kind of shows how closed it is. And then there, right here, it shows the pressure gauge coming off the front. This is actually the pressure gauge right here. And you can see kind of a pressure that you develop in this thing. So you turn up the oxygen real high. When you make a seal on this mask, the only place for that air to go is either through the mask into a patient's airway, over here into this bag, or out of that valve. And so you can essentially deliver CPAP through this mask. So what I usually do for a lot of kids, but of course if they're bigger, I'd turn the flows on a little higher, is actually close this valve a little bit, maybe turn this on to like 6 liters and 6 liters per minute of oxygen. Or, I mean, if you're in a pinch, just turn it all the way up and you can adjust the flow, or sorry, adjust the pressure with that flow control valve. Put this mask on the kid, give him a nice jaw thrust, hit the laryngospasm notch. You don't even have to touch this bag. But what this allows you to do is give this constant pressure through the mask into the patient's airway. What you're aiming to do, if you have these vocal cords that have closed down, you are giving constant steady pressure above it. If those vocal cords start to break open a little bit, that forced air will actually open them up the rest of the way. You don't, right in the midst of a laryngospasm, when you were developing hypoxia, the biggest thing to fixing that hypoxia is just instilling oxygen. You don't actually have to breathe for the patient. This is enough pressure that will drive into their lungs. Oxygen will be delivered into their lungs, into their alveoli, without you having to breathe in and out necessarily. Now that obviously doesn't work for real long, but that's how you break laryngospasm. You don't need to worry about squeezing the bag or any of that stuff. You just need to give a good seal on that mask. Now, why do I like these over ambu bags? Because ambu bags are everywhere, but I kind of think they're worthless in this situation. So why do I like these? Well, for starters, if you make a seal with this particular system, you will see the bag inflate. If you don't have a seal, that green bag right here will not inflate. It will stay like this, and you have a great visual indicator that something's wrong, and the patient will not be getting any of that oxygen or that pressure. Okay, so that's for one. So if you're doing this right, this bag will blow up and get real big. Number two, when a patient starts breathing on their own, you will see this bag go up and down, and you will hear out of this flow control valve, which you're going to have open just a little bit, you will hear the patient breathing, because it produces kind of a high-pitched noise that comes out of there, that whooshing air noise of the kind of the pop-off aspect of this. You will hear a patient breathing in and out. Even if they're really little, you will hear a tonal difference in that kind of high-pitched noise. None of this you get with an ambu. An ambu bag, you put on somebody, you squeeze the bag, and it goes wherever it's supposed to go, right? You also they're not designed for spontaneous respirations. This is designed for spontaneous breathing. So can you breathe spontaneously through an ambu? I think you can, but that's not the point. I want to know that you're breathing. I want to see it, because sometimes you can be breathing a little bit, you don't necessarily see real good chest rise and things like that. So that is why I think this is superior to an ambu. I think this should be in every bay in PACU that we're taking care of anyone at high risk for laryngospasm, or just any kids in general, again, because they have such a higher risk for this. And I'm going to try to make a separate video on the best ways to use that. If you've never handled one before as a PACU nurse, you need to, in my opinion. So I think we should get those stocked in PACU, to be kind of frank. So that's kind of how that goes. I think I've covered all the topic I wanted to on that, but I think they're a great invention. So treatment for this specific thing. If someone's having a laryngospasm, the basic tenets are this. You need to do two things. You need to remove the stimulus, should probably be first on here, but you need to change the plane of anesthesia. The only way we can do that, well, there's two things we can do, right? Make the anesthesia lighter or make the anesthesia deeper. These are the different ways to break laryngospasm. So the first thing we're going to do is administer 100% oxygen. At this point, you can't get too much oxygen. I don't care if they're a neonate at risk for retinopathy or prematurity or whatever. Give them 100% oxygen. You can do the Larson's maneuver, like we said, that jaw thrust and the laryngospasm notch. What that mainly accomplishes, that is basically the only way to lighten the anesthesia quickly. I'm trying to think of fun other ways to do it, but that's really it. You can say the word pain, you can do whatever you want, but what it is stimulating you to be more awake. So that is why that works. It also opens up the hypopharynx, moves things away from the vocal cords, and just provides a bigger space to breathe through. The third thing, and you could do 2 and 3 together, but positive pressure ventilation via one of these flow inflating bag circuits. And if that is not working, this also assumes you just have drugs just laying around. But either way, you can deepen the plane of anesthesia. There's different ways you can do that. One is with propofol. One of the things I picked up to date was a dosing scheme. Since I use propofol all the time, I'm pretty comfortable at just shooting from the hip and saying, I'm going to give this much propofol, and it should work depending on what size patient I'm taking care of. But a little more evidence-based version of that is 0.5 milligram per kilo up to 50 milligrams. 50 milligrams of propofol should break a laryngospasm for just about anybody of any size. Should. But in the case that it doesn't, basically what you can do is just take away the motor function. If someone's desatting really hard, you can't seem to fix it, give succinylcholine. 0.1 milligram per kilo, which is not much succinylcholine. This is not an intubating dose of this drug, but it's enough to relax things enough to where you can get air through. These doses can be repeated. Obviously, if you end up going down this path, you're going to have gotten a hold of a physician at some point, because I don't think we should just be willy-nilly giving out these drugs, but I just want y'all to be aware this is the treatment for it, okay? Alrighty, so that's laryngospasm. That's probably 75% of the airway disasters you're probably going to run into. And when I say disaster, it's because most of the other stuff causes issues, but not full-on catastrophe. To my knowledge, since we'll just go back a page and not start bronchospasm yet, to my knowledge, this is how Joan Rivers died. She went in for a procedure at some outpatient thing, somehow got a biopsy of her vocal cords, which I think there was a lot of angst in the medical community over, because I don't think she was actually consented for that. And some of this might just be hearsay or whatever. But after the procedure was over, she had a laryngospasm, and I think that's what caused her to become hypoxic enough that led to her death. I may be wrong on that. Some of that may be rumor, but I believe that's what actually happened. So like I said, laryngospasm is more of our big catastrophic problems. Not that you can't have a catastrophe with other types of airway issues, but it's just the one that comes to mind first. So now we'll move on. We'll talk about bronchospasms. Bronchospasms are a whole world of difference than laryngospasms. More often than not, they cause hypoxia and cause issue, but don't necessarily, you can still move air in and out a little bit. Laryngospasms, very often you can't move any air. So bronchospasms are not an upper airway issue. This is typically your lower bronchioles that actually cause this problem. Your larger main left and right bronchi can do this, but it's mainly the constriction of the smooth muscles in the lower airways that basically you can fill up the big pathways to your lungs, but not the parts that actually oxygenate things. This still results in pretty significant hypoxia, but it's typically a slower kind of hypoxia, and it can be slower to kind of pull them up out of it. This is where you actually hear wheezing when you listen to a patient. Laryngospasm, you're not going to hear wheezing. Again, you can take a stethoscope for laryngospasm and put it on the larynx, and you'll hear something real loud here in a minute if it's a partial laryngospasm and they are moving some air through. But for bronchospasm, it's typically just wheezing. Risk factors for this is a lot fewer. Again, anyone can do this, but the big ticket items are people with asthma, typically pretty crippling asthma or untreated asthma, can have this happen on emergence from anesthesia. That's going to cover COPD as well, because those are, a little bit interchangeable in terms of the lung reactivity, I guess I'd say. This is a smoker's thing, much less often with smoke exposure. This is usually people that are smokers. And then you can also run into this with people that are having allergic reactions. If someone's having an allergic reaction, the first thing you're going to notice is probably not a bronchospasm. It's probably hypotension, tachycardia, all that kind of stuff. But you'll definitely notice, a patient either complaining about stuff if they're awake, but if they're not awake, they'll start desatting. You'll listen to their chest and they'll have wheezing. So that can also be kind of an allergic response. Ways to prevent this. This is a little bit more tricky than a laryngospasm in terms of prevention, because a lot of these things you may or may not be able to do. So if you can delay elective surgery for people with current upper respiratory infections, much like laryngospasm, if they have different risk factors for this thing, that's definitely a consideration. If I get someone that comes in that's like, again, this real brittle asthmatic, and then they've had a recent upper respiratory infection, I might be more prone to say, let's not do this, than just a healthy person that might have had a recent upper respiratory infection. Of course, there's always caveats to all this. It depends like what kind of surgery it is, and whether or not it's more urgent / emergent, Stop smoking. Boy, this would be great if we could get people to do this more often. I have very little control over this because I see people the day of, and it's already too late. Having said that, most people that are smoking, I don't think most of the time a surgery isn't enough to make them all of a sudden quit smoking. It's usually takes a little bit more oomph than that. But if people quit smoking prior to elective surgeries, that's great. They need to quit doing so months in advance of the surgery, not just a week or so. But again, any amount of quit smoking will help. And then really the only prophylaxis you could do for this is give someone a nebulization treatment before even going back for a general anesthetic. There are times where I'll give people a duoneb treatment in pre-op that will hopefully hang on long enough for them to undergo a procedure, go to PACU, and that has been shown to help people out a little bit. I'm a bigger fan of nebulizers rather than meter dose inhalers because I like to give hospital grade stuff for what I'm doing rather than the little puffers. So treatment for this, again, if you have the ability to remove whatever stimulus there is, this is usually down in the lungs. The stimulus isn't something you can usually reach, but if somebody's had a recent bronchoscopy and they've been having bleeding and things like that, if there's any way to do any sort of, what do you nurses call it, deep snogging or whatever, maybe you can pull that off. That'd be cool. Changing the plane of anesthesia for this is kind of hard as well because this is, I think, less responsive to putting patients back to sleep, but the theory kind of holds sound, I guess. So with these patients, you're definitely going to, again, the first thing you do is administer 100% oxygen, and the pharmaceuticals that we can use. There's not really any physical maneuvers or anything you can do. The Larson's maneuver of the laryngospasm notch is not going to help in this situation. So one of the biggest things I like to give is duonebs over albuterol because I like to have as many drugs as possible working where you can. So the albuterol is I believe it's a beta-2 agonist, and that will help relax the smooth muscle in the bronchi. Ipratropium is an anticholinergic that also helps doing that. So that is probably my biggest recommendation. What's the dose? Whatever you can get in people. I think it's kind of hard to overdose somebody with that through a nebulization. I'm sure people would argue me on that, but something is better than nothing. So whatever dose you have around. For an adult, even if it's a kid, throw it into a nebulizer and just let them go. You can use an albuterol meter dose inhaler. You got to use some pretty high doses. 8 to 10 puffs was the recommendation on UpToDate, but again, that's more of a, I have a conscious person that can actually take this and do something with it. Meter dose inhalers have a much higher rate of sticking to the mucosa in the back of the mouth rather than actually getting inhaled. So again, I think this is more of a job for a nebulizer treatment, but whatever. IV stuff you can use. So anticholinergics, glycopyrrolate comes to mind. That's kind of a fan favorite of everybody's, but you can also use atropine. They do make IV ipratropium. Didn't even know that. Found that out researching for this thing. I don't think we carry it here, but it's fun to know. If someone is completely not responsive to any of this, and it is a life-threatening thing, you can give epinephrine. You're not given code doses of epinephrine, you're given very small doses of epinephrine. Somewhere in the realm of 10 to 100 mics IV, which is in a code, one of those big code syringes of epinephrine. I think the entire syringe, which should be, I think it's 10 mLs, is 1 gram. So 1 ml of that whole 10, 1/10 of that, is going to be 100 mics. And that'll blast somebody out of anything. I mean, they're going to be very hypertensive after that. But if someone's having an allergic reaction or something, and the only way to stop what's going on is that, then do it. You can also put people on magnesium drips, kind of similar to you do in OB. The magnesium will compete with the calcium in the smooth muscle and actually cause relaxation. The same way you can put some laboring patients on magnesium and stop uterine contractions. Same sort of theory behind that. So that is kind of how you treat bronchospasm. Again, call a physician, get somebody else around where we can start ordering all these things and give you all really good direction. But that's kind of the pharmaceutical aspect of that. And then that's it for me. Yeah. So I'd love to take credit for the PowerPoint, but I used it. I went to a website called SlidesGo and stole it from another medical talk. And so that's how there's all sorts of fun shapes and stuff on there. And then I use these links on UpToDate to kind of figure out what to talk about for you guys. So that's all I got for this. Click to exit. Okay, cool. What questions do y'all have? Or do you have questions?
I have a question. So do you, back in the OR, use those inflatable bag masks on all your patients?
Are you talking about this?
Yeah.
Okay, so in the OR, an anesthesia machine already has one of these kind of built in. It looks different, but there is a green bag involved, and it works the same way. So I do the exact same stuff for laryngospasm in the OR, but I don't usually use this. I'm usually using my anesthesia machine because it's already there and set up.
The reason I ask is because Dr. Scow, like most of his patients come out with those, so that's why.
And again, I need to do a better job of bringing most of my peds patients back with one of these as well, because I know that I just kind of want it there, just ready to go for that patient. I don't think the cost of this is so particularly damning that we shouldn't open one for every patient. I think the cost of an untreated laryngospasm is probably a lot higher. So I'm a big fan of these. I know Dr. Keller makes one of these kind of himself. It doesn't really have this flow meter on, but he pieces together some stuff that's a real cheap kind of way to do it. But I like these. I forget who makes them, but it's a good product. So, any other questions?
I just like, if we could get a demo on that, like you said, that would be awesome.
Yes, I will make a demo on that.
We recovered like a little COVID positive kid in endo, and I was like, there's not an ambu bag in here. Like, what am I supposed to do? And we didn't need it, but there was one of those. But I have no idea how to use it.
But you have no idea how to use it. So
yeah, so it's like great that it's there, but
it's super.
If we could get that would be awesome.
It is super easy to use, and I will figure out a way to show you guys.
Thanks.
Yeah. Any other questions? Anybody else? Okay. See y'all in a month.